Dr. Shah, we can start. Good morning. Today we have a ward round scenario discussion of blunt trauma abdomen. Dr. Nitesh Pradhan is a third year junior resident appearing in the exam, will present, and Professor Sudeb Shaha, professor and head of surgery at NIS Medical College, will moderate the session today. Nitesh, you share your screen and read the scenario and wait for Dr. Shaha to proceed.
Yes, sir. Sir, is the screen visible?
Yes.
30-year-old male patient sustained a road traffic accident, presented with a pain abdomen and abdominal distension with suspicious of abdominal injury. How will you proceed?
Okay.
Hello.
Yes,
sir.
Yes, Dr. Shah.
Am I audible?
Yes, you're audible.
Okay. So we have a 30 years male patient sustained road traffic accident with pain abdomen, abdominal distension with suspicion of abdominal injury. How will you proceed? I feel can we be a bit more specific?
Yes,
because
sir.
Abdominal injury as a whole is a big thing. I don't think that.
Now we discuss the general management and then specific one you take. We will not discuss the whole.
Oh,
okay. Yes. General management and then followed by one specific injury.
So the simple thing I ask you is on initial examination, what are your findings?
Yeah.
Sir, initially, sir, we patient with trauma, sir, will start with will follow the ATLS protocol, sir, which includes sir primary survey, secondary survey, sir, and sir, then we'll do the definite management. Sir, in primary survey, sir, we'll look for sir airway, breathing, airway and cervical spine stabilization, breathing, sir, circulation, visibility, and exposures. Sir, if a patient is stable, sir, then we'll go for secondary survey. Along with sir, primary survey, sir, we'll do resuscitation simultaneously. And sir, if the patient is stable, then sir, we'll go for the secondary survey, in which sir, we'll do head-to-toe examination.
For the time being, let us stay with the primary survey. So initially, as you said, what are the primary surveys? Once more, what does it include?
Sir, it includes airway, cervical spine stabilization, sir, breathing and ventilation, sir, circulation, sir, then disability and sir, exposure and environment.
Along with airway and cervical spine stabilization, they both usually come together. Along that, we have another thing very important, which some books have already mentioned, that is massive hemorrhage.
Yes, sir.
So as someone is taking care of the airway, someone else simultaneously has to take care of any massive obvious hemorrhage, whichever is there. Yes, okay, fine. So what do you find? As you have said, it's abdominal injury, and so it indirectly means that all other areas are normal, right?
Yes.
Okay, so then let's proceed with abdominal injury.
Sir, so we'll proceed with secondary survey, in which sir, we'll do the detailed exam. Excuse me, sir. The detailed examination of abdomen, sir, in which we'll do first. Sir, sorry, sir, we'll start with history. Sir, in history, sir, we'll ask for the mechanism of injury, sir, site of injury, and sir, nature of the injury. Sir, then we'll ask for the complaints, pain abdomen, sir. Pain abdomen, sir, we'll ask for the site, sir, character, sir, any radiating, any aggravating relieving factors. Sir, we'll ask for hematemesis. Then, sir, sir, history of vomiting, and sir, if sir, injury sustained to sir, kidney or bladder, sir will ask for.
No, you can't ask for kidney injury, isn't it? You'll have to ask for a certain areas in the abdomen. You would like to know which areas in the abdomen the patient has sustained the injury, right?
Yes.
Yeah, basically that, along with the mechanism of injury also, right?
Yes.
Whether
Yes.
the patient was sitting in an automobile, then you can expect either steering injuries or dashboard injuries, or he was wearing a seat belt, then seat belt injuries and things like that.
Okay, sir.
Okay, we would actually write the mechanism. We would like to know, just because we can indirectly assume certain things.
Yes, sir.
Okay, yes, and then we will shift our attention to areas of the abdomen which are injured. Okay,
Yes,
please proceed.
sir. Sir, will also ask about, sir, any swelling in the abdomen. Sir,
Yes,
then, sir, on examination, sir, on inspection, sir, we'll see any bruising.
Nitesh,
Yes, sir.
in the
Yes, sir.
history also, you should ask whether he has got any hematuria.
Yes,
whether
sir.
he has got any
Sir,
bleeding
hematuria,
parenchyma.
sir. Yes, sir. Hematuria, sir. Any pain in the loin, sir.
Then vomiting, any vomiting of blood.
Yes, sir. Vomiting, hematemesis, sir.
So this symptom may suggest a specific injury. Okay, carry
Yes,
on.
sir.
Okay.
Yes, sir. Sir, then will sir do the examination, sir. Sir will first do the, sir, general examination, in which, sir, will see the vitals, sir, including blood pressure, heart rate, sir, then sir, respiratory rate, sir, then sir. Then sir will go for abdominal examination, sir, on which inspection, sir, in inspection, sir will look for, sir, any bruising, abrasion, sir, any ecchymosis over the umbilicus or flank, any distension of the abdomen. Then sir will look for the movement of the abdomen. Sir, apart from that, sir, we'll look for a mark of, sir, like seat belt marking, or sir, steering wheel marking, like, so, look for that.
Look for any bruising over the abdomen, right? If
Yes, sir.
there is bruising, that has to be noted, and we will have to later on concentrate on those areas.
Yes, sir.
Right. Okay, then.
Sir, on palpation, sir, sir, we'll look for temperature over the abdomen, sir. Then, sir, we'll look for signs of peritoneal irritations, like hardening, rigidity, rebound tenderness. Then, sir, then, sir, look for, see for the fullness, and, sir, in hemoperitoneum, sir, the abdomen will be duffy consistency. Doughy consistency. Then, sir,
I mean, hemoperitoneum, you can't say straight away, right? You can at the most say that there will be fluid in the abdomen.
yeah, yes, sir.
So you cannot exactly say it is hemoperitoneum. Anyway.
Yes,
Okay,
sir. So then also, sir, we'll look for the crepitation over the lower thoracic cage, sir, both the side, to rule out the liver splenic, also to suspect a splenic and liver injury. So then,
so what investigation can you do at the bedside right now?
Sir, bedside, sir, sir, we'll go for fast, sir.
Yes.
Sir, if fast is not available, sir, then we can go for the diagnostic peritoneal lavage.
Now, when we are discussing an injury, trauma, it can be assumed that yes, fast will be available, right?
Yes.
Fine. You please tell us, what do you mean by fast? What do you mean by e-fast? And before
Sir,
that,
fast is.
Before that, we have assumed that you have done all examination of the abdomen, that is a thorough examination, including digital rectal examination, right?
Yes, sir. Sir, we'll do sir DRE, and sir also sir will look for sir will do vaginal examination.
What will you look for in a rectal examination?
Sir, we'll look for if any blood in the blood mixed stool or blood in the, and sir also bony penetration.
Yeah, exactly. So we will look for mainly blood, and of course anything else, as you said, that any any abnormal findings in the form of something pressing from outside.
Yes, sir.
Right. Fine. So let us proceed to fast and e-fast. Yes.
Sir,
What is one
fast.
look for in case of fast?
Sir, in fast, sir, we'll look for sir, we'll look for sir, any collection over the abdomen. Sir, first, sir, we'll look for sir four areas we'll look for. Sir, one is pericardium, then sir hepatorenal fossa, then sir splenorenal fossa, and sir then retrovesical fossa, sir. And sir, in E-fast, sir, we include both pleural spaces, sir.
Yes. If necessary, we will go for pleural spaces, and that too with whichever side, as we come to know with the examination, it may be left side, right side, or whichever. Right.
Yes, sir.
Okay. Now, on examination, what else have you found? Let us talk about the hemodynamics.
Pardon, sir.
Let us talk about the hemodynamics.
Okay, sir.
What have you found on examination?
Sir, hemodynamically, sir, sir, if sir, hemodynamically, if patient.
Is this patient hemodynamically stable?
Yes, sir.
And what do you mean by hemodynamically stable?
Sir, hemodynamically stable means, sir, sir, blood, sir, sorry, sir, vitals should be within the, sir, should be normal, sir. Then the no features of.
I don't understand what is vital.
Sir, sir, we'll look for blood pressure, sir, heart rate.
I request you that in examinations, please elaborate. Don't say vital.
Yes, sir.
That is a part of colloquial language.
Sorry, sir.
Tell us, I mean, in details, what pulse, what is the pulse, what is the blood pressure, and things like that. Yes.
Okay, sir. Sir, on examination, sir, found sir blood pressure is sir like sir 110/70, sir. If you assume, sir, then heart rate is, sir, 90.
Is absolutely normal, right?
Yes, sir.
Okay, so I mean, below what will you consider to be abnormal?
Sir, in sir, blood pressure systolic BP should be less than 90, sir, and sir, sir, heart rate more than 100, sir.
So basically, a systolic more than 90 is considered to be hemodynamically stable, right?
Yes, sir.
Okay, then proceed.
Sir, heart rate, sir, sir, more than 100. Sir, respiratory rate, sir, more than 20, 20, sir.
Okay.
Sir, then, sir, oxygen saturation, sir, less than, sir, 94. And sir,
Yes.
increase, then, sir, temperature, sir, look for the temperature whether the patient is hypothermic or sir, febrile. Sir, then, sir.
So you consider that your patient presently is hemodynamically stable, right?
Yes, sir.
So we usually put them into three categories, that is physiologically normal, physiologically non-compromised, and physiologically compromised, right?
Okay. Yes, sir.
Physiologically normal means a patient where investigations can be completed before treatment is started. So physiologically non-compromised, basically investigation is more limited. Okay.
Yes. Yes, sir.
Establishing whether the patient can be managed non-operatively, whether things like, angioembolization, if available, can be used, or whether surgery is required.
Yes,
And
sir.
last, where we consider it to be physiologically compromised,
Yes, sir.
investigations need to be suspended as immediate surgical correction takes the upper hand.
Yes,
Fine.
sir.
Okay, fine. So you consider your patient to be hemodynamically stable.
Yes,
Okay.
sir.
And then you have already completed your EFAST, right? So what are your
Yes.
findings on EFAST in this particular patient?
Sorry. Sir, there is a collection in the hepatorenal pouch, sir.
In the hepatorenal pouch. Hello.
Yes, sir.
Okay, fine. Then what do you want to do now?
Sir,
That means we can assume that all other areas you
sir,
have not.
if patient is our patient is hemodynamically stable, and sir, fast is positive, sir, then sir will go for CCT whole abdomen to look for the severity of injury, sir, and anatomic sir,
So basically,
severity of injuries and then extent of injuries are also, sir.
in a hemodynamically stable patient, if you find your fast points towards one particular area of the abdomen where there is a collection, which you can assume to be hemoperitoneum because it is a patient who has a history of trauma, and
Yes.
you said that the patient is hemodynamically stable. In these conditions, the obvious choice for an investigation is always a IV contrast enhanced CT scan.
It is,
of the
yes,
whole
sir.
abdomen. And we can assume that by the time you send the patient for a CT scan,
Yes,
a
sir.
urea protein report is available, right?
Yes, sir.
Fine. So you have asked the patient to get a CT scan done, and nowadays, we have the CT scan investigation. This resource is available within the emergency department,
Yes, sir.
and nowadays, in good centers, they can be done very quickly,
Yes,
right?
sir.
And
Yes,
in
sir.
certain marginally compromised patients, so these areas are gradually becoming a bit blurred, because previously it was considered that CT scan can be done only in perfectly hemodynamically stable patients. But nowadays we say that yes, even in marginally compromised patients, you can get a CT scan done, because
Yes, sir.
during the process of CT scan, the resuscitation measures are being continued, right?
Yes, sir. Yes, sir.
With modern CT scan machines, we can get the CT scan done very quickly as compared to what it used to take previously.
Yes,
Okay.
sir. Yes, sir.
And what is whole body CT scan? Any idea?
Sir, whole body CT scan, sir. Sir, when we sir don't know, sir, where is the injury, sir, then sir, then sir that then it includes, sir, CT chest, sir, abdomen, pelvis, sir.
Yeah, basically in a seriously injured patient, where you think there are multiple injuries in the torso,
Yes, sir.
right? And also maybe some injuries in the limbs, you can rapidly get a CT scan done right from head to toe.
Yes, sir.
Right? Yes.
Yes, sir.
That is a whole. This is basically applicable only for trauma, not for
Yes.
anywhere else. Okay. Yes. Then proceed. So you have got a CT scan done.
Yes,
What
sir.
do you expect in a CT scan of this patient? What do you expect?
Sir, in this patient, sir, sir, there will be a sir, chance, sir, there will be an injury to the liver, sir.
You can expect certain injuries to the liver.
Yes.
Right? Fine.
Yes.
Now, I would request you to, let us know, what are the different injuries to the liver?
Sir, grades of injuries, sir.
Yes.
Sir, grades of injuries, sir.
Carry on.
Yes, grade 1, sir. Sir, there will be a subcapsular hematoma, which is non-expanding, sir, which is less than 10% of the surface area. Sir, then sir, sir, there will be a capsular tear and
Now, first,
sir,
tell us how many grades? How many grades are there?
sir, 6.
Totally, there are 5 grades, right?
Yes, sir.
We are talking of AAST, that is American
Yes, sir.
Association for Surgery of Trauma, right? There are 5 grades. This is the 2018 version.
Yes, sir.
I don't think there is any version after that. That is the latest, where you have 5 grades of injury starting from grade 1 to grade 5.
Yes, sir.
Okay. Yes. Now we don't have that much time. So tell us in a gist, what are the different grades quickly?
Sir, grade 1, sir, subcapsular hematomas are non-expanding, less than 10% surface area. Sir, then there will be a laceration. Sir,
Again, you may
capsular
have a parenchymal laceration with that, which is again less than 1 centimeter.
less than 1 centimeter, sir. Grade 2,
And
sir,
capsular tear. Right?
Yes,
So
sir.
these things constitute grade 1. So obviously, subcapsular hematoma and parenchymal laceration, when more than this, to the extent of 10 to 50, and I mean, yeah, proceed.
Sir, grade 2 is sir subcapsular hematoma, which is non-expanding. It involves 10 to 50% of the surface area, and sir, sir, it is less than 10 centimeter in diameter. Sir, then there will be a capsular 1 to 3 centimeter parenchymal depth laceration, sir. Sir, grade 3 is subcapsular hematoma, more than 50% of the surface area, or sir, expanding or rupture hematoma with an active bleeding, sir. Sir, then laceration, sir, more than 3 centimeter parenchymal depth, sir. Then sir, grade 4 is sir, parenchymal disruption.
Where you have segmental hilar
Parenchymal
vessels.
disruption, 25 to 75% parenchymal disruption, which includes 1 to 3 coinad segment of the petticoat, sir. And sir, then sir, grade 5 is sir, more than 75% parenchymal disruption, include more than 3 coinad segments, sir. Also, sir, there will be a juxtahepatic disruption, juxtahepatic vessel disruption, sir.
Yes.
Then, sir, yes, sorry.
So we have 5 degrees.
Yes, sir.
Okay, fine. So when will you consider a patient of liver trauma, or rather, let us make it more basic. In case of a liver trauma, what kind of management would you like to do? Say in this particular patient, or in general, most of the cases.
Sir, if patient is hemodynamically stable, sir, we'll go for non-operative management, sir. We'll go for conservative.
And this patient is hemodynamically stable, and there is a demonstrable liver injury in the CT scan. Yes. Now, after this, we will do whatever what is called staging, right? We will try and whatever is visible in the CT scan.
Yes.
We will assume, or we will make sure we compared with this grading, right? We will grade the injury.
Yes, sir.
That is number 2. And lastly, you will have to examine these trauma patients very frequently, right?
Yes,
because
sir.
now the patient was previously hemodynamically stable, but you have to make sure that the patient remains stable all along.
Yes, sir.
Right?
Yes, sir.
Suddenly you find there is some bleeding, right?
Yes.
So you will have to act very quickly. Okay.
Yes, sir.
Usually in most patients, what do we do? NOM. That is the new term.
No, sir. Non-operative management, sir.
Non-operative management. Yes. Tell us a bit more in detail. What is non-operative management?
Sir, non-operative management, sir. Basically, sir, will will give a conservative management, sir, and also, sir, sir, will do serial sir, abdominal examination, sir, along with follow up, along with sir, serial fast, sir, it is indicated in the patient with hemodynamically, sir, those patient with hemodynamically stable. Then, sir, solid, stable patient with solid organ injury, sir.
Yes.
Then, sir, there's no features suggestive of hollow viscous injury. Then, sir,
Basically, it is an initial non-surgical management strategy of a solid organ injury, which usually consists of observation,
yes,
but
observation.
may include certain other procedures like
Sir, angioembolization.
certain endoscopic procedures and certain endovascular procedures. That is how
Yes, sir.
we have defined what is non-operative management. Okay,
Yes,
fine.
yes.
So what are the prerequisites of
Um,
this type of management?
sir, prerequisites,
When
sir.
you consider these type of managements, what are you expected to do? So number one is you have to have intensive monitoring,
Yes, sir.
intensive round the clock monitoring.
Yes, sir.
And we have already done a CT scan to identify the injured organ, and we have graded the severity of injury, right?
Yes, yes, sir.
So we have to make sure that we have this patient might need operation anytime.
Yes,
So,
sir.
round the clock operating theater availability should always be there.
Yes, sir.
And along with that, a 24-hour lab and blood bank facility, right? So these things are mandatorily required when you undertake NOM.
Yes,
Okay?
sir. Yes,
Fine.
sir.
Fine. Next. Let us talk a bit more about this kind of management. What are the advantages? What are the disadvantages?
Sir, it can reduce the rate of we can prevent sir unnecessary abdominal exploration, sir. Then, sir, it will decrease the hospital stay of the patient unnecessary, sir.
But
Sir,
explorations, therapeutic abdominal exploration, right?
yes, sir.
So previously we used to talk of as negative tagotomy. That is a colloquial term, right? So
Yes, sir.
we will call it non-therapeutic abdominal exploration. You are correct, because this management remarkably reduces the rate of non-therapeutic abdominal exploration. Okay, and
Yes, sir.
an overall success rate is around 75 to 90%.
Yes,
This is
sir.
an overall success rate of this kind of management. Number three.
Sir, sir, it prevents unnecessary administration, sir, of blood and blood products, sir.
Yeah, obviously,
It prevents sir massive transfusion.
yeah, if necessary, we will have to do that.
Yes, sir.
Right. And most importantly, it preserves organ function.
The organ function, sir. Yes.
That is very important. And in centers who have been doing it, they have labeled this particular management as a very safe form of management.
Yes, sir.
Right. What are the disadvantages?
Sir, disadvantage, sir. Sir, missed injuries, sir.
What missed injuries?
Sir, like any hollow organ injury or diaphragmatic injuries.
Exactly. So when you are dealing with perforation of the gut, right?
Yes,
this
sir.
may not be clearly visible in
Yes,
a
sir.
CT scan initially, right?
Yes, sir. Yes, sir.
So that might be because the CT scan has missed that, and you have considered that the injury is limited to a particular solid organ.
Yes, sir.
So in that case, that is why the importance of frequent examination of these patients come in, right? The monitoring system should be very, very dependable, should be accurate. Okay. Fine.
Yes, sir.
What else can we have?
Sir, a patient can have delayed hemorrhage, sir.
Yes.
Then, sir.
So that is why you have to have your blood transfusion services ready and available all the time, round the clock. Yes. Next.
Yes, sir.
Next.
Sir, then delayed complication maybe, sir, maybe associated with non-operative management, sir, like sir, liver abscess or
yes, you may have certain infective complications.
Infective complications, sir. Yes, sir.
So in the form of?
Sir, in the form of, sir, sir,
In the
blood,
form of
blood,
devitalized tissue, either from
devitalized.
the organ. Yes, mostly from the organ, because certain parts of the organ become unenhanced on CT scan, right?
Yes, sir.
So they are devitalized, that means they don't have a supply and they can be infected.
Yes, sir.
And also you can have infection of collections within the peritoneal cavity.
Yes, sir.
It could be bile, it could be blood, right? So these
Yes,
things are always there. Okay, fine. What else you need to do along with this?
sir.
You may do some facilities for endoscopic
Yes, sir.
facilities. Say, for
Yes, sir.
example, like an ERCP.
Yes, sir.
Or you may also have to, because we were talking of certain infective complications.
Yes, sir. Then
before the
percutaneous.
Yes, percutaneous drainage.
Yes, sir.
Has to be a guided drainage, obviously.
Yes, sir.
So you will need these associated services. Also, as you rightly pointed out some time back, that you will also need some embolization services.
Yes, sir.
This non-operative management is very, very important. Non-operative management means, I mean, these particular things, endoscopic, ultrasound guided aspirations, and in certain cases, you may need to have angiographic embolization. So these things should be available all the time, right?
Yes, sir.
And how long do you want to continue this non-operative management? Because during this period, you have to be on your toes, right?
Yes, sir.
You have to examine this patient very frequently.
Yes, sir.
How frequently?
Sir, sir, 4 hourly, sir.
Clinical examination has to be done at least 4 hours.
4 hourly, sir. Yes, sir.
Yes. If necessary, even more frequent.
Yes, sir. Hello? Yes, sir.
Investigations like, complete blood count and ABG.
Sir, yes, sir.
Have to be done at least,
6 to 12 hours.
Yes. Twice a day or maybe even frequently if necessary. And
Yes,
certain baseline investigations are required. For example, you have to know the coagulation profile of the patient, things like that, right?
Yes, sir. Yes, sir.
Now, when will you consider that? I mean, we will have to now operate.
Sir, when, sir, the patient is hemodynamically unstable.
Now let us talk of, yes, clinical. Clinically, when you find.
Sir, clinically, sir, we will find it.
This patient frequently, as we have already mentioned. So, on clinical examination, what will you find which will make you think that this particular patient needs to be operated?
Sir, sir, in clinical examination, sir, sir, when sir, blood pressure is sir, less than 90, sir, then heart rate is more than 100.
The patient now has started to have hypotension.
Yes, sir.
Hypotension. Along with that, you will have certain others, like you may have abdominal distension.
Yes, sir. Then, sir, any signs?
You may also have intraabdominal hypertension.
Yes,
right?
sir.
Yes. So these things, along with say for example, I mean, the abdomen has become much more tender.
Yes, sir.
Right? Yes. So these things will have to, of course, in certain cases, they will be corroborated with lab reports. Like, for example, there will be a fall in the hemoglobin.
Yes, sir.
It is having increased count. Right?
Yes, sir. Yes, sir.
Yes. So in certain cases, you may have to repeat the CT scan. Let us not forget that. Right?
Okay, sir. Yes, sir.
So these things will tell you that yes, you will now have to consider operative intervention. Okay.
Yes, sir. Yes, sir.
And along with that, we may also have to undertake ultrasonography if necessary, a repeat CT scan, because that involves radiational exposure.
Yes,
So
sir.
before you go for a repeat CT scan, make sure that you have considered ultrasonography as another choice.
Yes, sir.
Yes, fine. Yes, Makhunda? You want to add anything for this non-operative management of liver injuries?
Yes. Another important thing is while doing the initial assessment, you should not forget to do a chest X-ray. A plain
Yes.
chest X-ray can
Yes,
show
sir.
free gas under diaphragm, and
Yes,
that
sir.
is one prime indication for doing a laparotomy for abdominal trauma.
Yes,
Because
sir.
peritonitis, you have to go for laparotomy. Okay.
Yes, sir. Yes,
And then
sir.
other part is well discussed that one should do a good general assessment, and then depending on the injury, you have to go for either conservative or surgical treatment. And in between now, previously one prime indication for liver injury was continuing bleed. Now
Yes,
that
sir.
we can manage with therapeutic embolization, that is
Yes.
now available in Calcutta also, and this is amenable for a abdominal injury trauma. Otherwise, we have discussed the full part. Yes, the other injuries will take in separate classes. Okay.
Yes.
Yeah.
So what do you want to do? Suppose in a patient you have opened up a patient and you find a liver injury. What is or in other words, what are you expected to do?
Yeah.
Sir.
There are other injuries, and you find liver injuries.
Yeah, a few words on operative management of liver injuries.
Sir, after opening the abdomen, sir, when we'll find the liver injury, sir, we'll do the perihepatic packing along with the resuscitation.
No. You see, assess the injury. If it is
Yes,
just
sir. Yes,
a
sir.
hematoma, not expanding, don't
Yes, sir.
disturb
Yes,
that.
sir. Yes,
Okay.
sir.
It is
Yes,
not
sir.
necessary to explore. That depends on how is that you have given us general question. You find liver injury. So
Yes, sir.
your step will depend on what you find.
Yes, sir. Sir.
Now, before getting into frank operative management, will you consider laparoscopy?
Sir, yes, sir. The patient, sir, a patient is stable, sir, and sir.
Yes, the most important thing to remember here is there is no place for laparoscopy in an unstable patient.
Yes, sir.
Right? Yes. So you will consider
and even in stable patient, the person who will be venturing for laparoscopy has to be a very good experienced laparoscopist. You see, it is not somebody's job that will teach occasional laparoscopy. You see, it's a situation abdominal trauma. Patient may become unstable anytime.
Yes, sir.
Okay, so you have to have a experienced person who may venture for doing a laparoscopy for abdominal trauma.
Yes, sir.
Basically, laparoscopy can be divided into three parts. One is screening to exclude a penetrating injury.
Yes, sir.
With breach of peritoneum, because breach of peritoneum is very well seen with a laparoscopy. That is one thing laparoscopy does very well, right?
Yes, sir.
Number two is diagnostic, finding evidence of injury to a viscera, and it can basically, maybe it will tell you something about the location, right?
Yes, sir.
It can tell you that the other three corners of the abdomen appear to be normal. There is no blood, no collection, nothing. Maybe only in one particular corner there is a problem. So that will tell you about the localization.
Yes, sir.
Okay? And secondly, in certain cases, you may be able to repair the injury with laparoscopy.
Yes, sir.
But always remember, it is very difficult to exclude all intra-abdominal injuries laparoscopically.
Yes.
Right? So these are certain fundamental things. So no laparoscopy in an unstable patient. A very experienced person has to be doing it, and then it is not possible to exclude intra-abdominal to exclude all intra-abdominal injuries with laparoscopy. So these things you have to remember while talking of laparoscopy in case of trauma. Okay,
Yes, sir.
and a few words about operative management of liver injuries. They can be summarized by 4 P's. What are the 4 P's that is done? One you have already mentioned, that is
Sir,
pressure.
perihepatic uh,
Pressure.
pressure. Yes, sir. Pressure.
Because we use pressure for all kinds of bleeding when
Yes,
we
sir.
operate. Whenever there is a bleeding, we try and put some pressure in with the form of your finger or
Yes,
with a mop or with a piece of gauze. So pressure comes first. Okay,
yes,
number
sir.
one. Number two,
Sir,
plug,
back.
plug, plug. For example,
Okay.
there is a penetrating injury into the liver.
Yes, sir.
Right? So this
Yes.
penetrating injury can be plugged with, say, for example, a Foley's catheter. You can insert that, and maybe you can inflate the balloon, right? So that is
Yes.
possible in certain cases because beforehand what is the nature of injury what inside the liver because you have had a CT scan done, right?
Yes, sir.
Then comes pack, as you have already said, packing the liver, right,
Yes,
in
sir.
certain
Yes.
areas and maintain the anatomical feature or the shape of the liver.
Yes, sir.
And lastly, one of the most important things is Pringle maneuver. What is
Yes,
Pringle
sir.
maneuver?
Sir, sir, Pringle maneuver is, sir, clamping the, sir, hepatidinal ligament which contains hepatic artery and portal vein, sir, by entering the laser sac, either by the vascular clamp, sir, with the vascular clamp, sir. Sir, it decreases the blood flow to the liver, sir, and we can assess the um, injury, sir. Also, it differentiates from the bleeding from the hepatic vein from the hepatic artery and portal vein, sir.
So it basically stops all blood flow into the liver,
Yes, sir.
right? But
Yes,
one
sir.
thing it doesn't take care of is some back bleeding from the hepatic veins and the intrahepatic intravena cava,
Yes, sir.
right? So bleeding from there will not be taken care of by this Hogarth Pringle maneuver. Okay, fine.
Yes, sir.
So this is basically a temporary procedure. How long can you hold that vascular clamp?
Sir, usually, sir, 30 minutes, sir.
I would say not more than 10 to 15 minutes at the most, right?
Yes, sir.
And in that, during that period, you have to do all the other P's, right? You have to aspirate whatever blood is there,
Yes, sir.
right? The pressure, the plug and pack has to be done during that period, and you will
Yes, sir.
have to release and see what is the result of all your this packing and pressure. Then you may have to do it again, right?
Yes, sir.
So it can be repeated. Yes. Okay.
Yes, sir.
After a period when you allow the blood flow, then afterwards you can always repeat this maneuver when the abdomen is open, right? The Pringle's maneuver is usually not allowed laparoscopically. That is one thing you have to remember. Okay, fine. Now, regarding, say, for example, injury to these blood vessels which take blood into the liver, the hepatic artery and the portal vein.
Yes, sir.
If there are any injury to these blood vessels, what can you do?
Sir, sir, Pringle maneuver, sir, one, sir.
Not due to Pringle maneuver. That is not what I meant.
Yes.
In case you find there is an injury to the blood vessels which carry blood to the liver.
Yes, sir.
So yes, what do you
Sir,
do?
sir, we can do, sir. Sir, selective vessel ligation, sir, hepatic artery ligation.
Now, first and foremost, let us remember that wherever possible, you will have to repair this blood flow. Even if it
Yes,
is
sir.
hepatic artery, you will have to try and repair it. If necessary, wait for some time and get experienced help so that the injury can be reconstituted, and of course, that is the best possible way out. And one
Yes.
thing you have to remember, portal vein has to be repaired. There is no other way out. You can't ligate the portal vein and come off.
Yes, sir.
Portal vein has to be repaired.
Yes, sir.
For one. Number two, the hepatic artery may be compromised, but try and do it if possible.
Yes, sir.
Yes, that is, I'm talking of repair of the hepatic artery, because in people who usually do trauma, they are very well experienced in taking care of vascular injuries also,
Yes, sir.
right? Yes. So you will have to repair all these injuries whenever possible. At the most, if you compromise with the artery, not with the portal vein. That is very important. Okay. Why
Yes,
do we say that you can't do anything, compromise with the portal vein? Because that carries the maximum amount of blood.
Sir,
Okay.
because it carries the sir around 80% of the blood flow to the
Yes.
liver. Sir.
Exactly. I mean, there is no other choice. You will have to do something about the portal vein. You can't tie it off and come away. Fine.
Yes, sir.
Okay. And under these, here I would like to mention a point that in case in such conditions you have packed the liver and you find that yes, the bleeding has now stopped.
Yes,
Let
sir.
us remember that you can leave these packs inside.
Yes, sir.
Right? In case of trauma, you can leave these packs inside with a plan to remove it later when you will have to get in again. All
Yes,
you
sir.
have to do is you have to mention detailed notes.
Yes, sir.
Yes. So you are allowed to keep intra-abdominal packs in case of trauma and maintain detailed notes and plan for a reoperation. Right?
Yes, sir.
Say
Yes, sir.
within 48 to 72 hours.
Yes, sir.
When the patient has stabilized and is in a better condition.
Yes, sir.
Yes, Mahunda will have something else, something to say here. A small question: how much blood can EFAST detect?
Sir, it should be more than 100 ml. Sir.
Yes, not less than 100.
Yes, sir.
Yes, Mahunda.
Yes. Now we have discussed the most important part of liver injury. Okay. So that is the correct approach in your ward round scenario examination. Okay. Thank
Yes,
you,
sir.
Dr. Shah. Thank you.